So I've got two talks to give this afternoon, and the first one is because they couldn't get anyone from NICE to come and talk about the quality standards for healthcare-acquired infection. So I had my arm twisted because I think this is part of my job description, is come and talk to people with my NHS improvement sort of hat on. But I've highlighted a few people in the audience who would give a far better talk for future occasions. So watch out. Okay, so I'm going to talk to you about the NICE quality standard for healthcare-acquired infection. It came out in February 2016. Hands up who filled in for their organisation the quality standard review. Anyone? I can see a pencil twitching once. Two pencils. Not many of you. All right, that should make it interesting then. Hands up who've seen their own organisation's plan. A few more. Hands up if this is totally new to anybody. No, so you all know something about it. Good. Okay. So first of all, I wanted to sort of put up what we had already. So we already had, that came out in November 2011, NICE healthcare-associated infections, prevention and control. So that was there already. And actually, the quality standards, which has actually been taken from those, is almost exactly the same. It's just really making you do that assessment on it. We already had the NICE infection prevention control quality standards that came out in 2014, which really focused on cooperation, catheters, antimicrobial stewardship, and hand washing. And so there will be an action plan in place for there. And then we had an update to the Health and Social Care Act 2008, and that took place in 2015. And it included antimicrobial stewardship in there. So there's lots and lots of things, in theory, that are driving really sort of good practice on there. So what do I think that this adds? Well, it adds a mandatory self-assessment and a development for an action plan. And again, this is hopefully focusing the hospital boards on infection prevention control. And I put in brackets again, because there's been so much legislation out there and guidance that their mind should never almost disappear on it. I think the big thing this probably adds, and probably reinforces if it's not there already, is actually making providers and commissioners, certainly in local health economies, work together if they weren't sort of doing it already. Hands up if you're in the audience and you work in a local health economy where the providers and commissioners don't all get in the room to discuss healthcare-acquired infections or infection prevention control. Anybody? Got one down here. Anyone else? I can't see, squinting. A few people up at the back. This may well help you then, because I think most people are probably getting on with it. And the most important thing is it's probably promoting the wider antimicrobial resistance sort of agenda, rather than trying to focus purely on healthcare-acquired infections. So, and we've spoken about it already earlier today, we focus very much on C. diff, very much focused on MRSA bacteremias, and we know the huge improvements that we've seen in patient care on them. So there are 5 quality statements. Hospitals must monitor healthcare-acquired infections and other infections of local relevance to drive continual quality improvement. Hospitals must work with local health and social care organisations, and I think that's really important that it drags in the wider social care with the council, looking at managing the risk of infections in hospitals and from community outbreaks. Hospital staff have individual objectives and appraisals. That's not new. That's been well and truly embedded in everything we've had already. Hospitals involved in infection prevention control teams in the building, refurbishment and maintenance of hospital facilities. And I would hope that was already there. There's enough legislation out there that we've got everybody involved in that. And then people admitted to, discharged from or transferred between or within hospitals have information about infections and associated treatments shared with infections and associated treatments shared with health and social care staff. And hopefully that's already been embedded in practice from the things we've had already. One of the things that the NICE guidance on antimicrobial stewardship has done is we now actually have to list what treatments people have actually had in there. And I don't think we've been particularly good before. We've said if someone's had an infection, we've not told them what they've been treated with. So I'll try and whiz through some of these, and we'll spend a bit more time on the second one. So the first one is about the improvement. There's a quality statement that talks very much about mandatory national and local surveillance on there, but it only covers a small number of healthcare-acquired infections. But it now talks about the monitoring of other infections. So we've had guidance out there for CPEs that we've spoken out already. But hopefully this will get people to start talking a bit more about surgical site infections and others. And I'll show you some examples. And our second speaker will focus on SSRIs a bit later on. And again, this should inform practice to review our effectiveness and responses to make sure they're working. So a bit about surveillance. My experience of the 5-year antimicrobial resistance strategy has been that the real success of it so far is the increase in surveillance. The amount of data that's coming through is much greater than we had before. And I'll show you a few sort of slides from the PHE fingertips, which is probably the greatest facility for sharing data anywhere in the world. We do more surveillance in the UK than any other country in the world. So we should really make the most of the data we have. So again, the surveillance is about having the structure, data source and outcomes, so local arrangements to monitor HCIs and other infections, then using the results from sort of the monitoring to form quality improvement, looking at incidents of healthcare associated infections. And I won't mention all the other bits that are listed on there, so they're ones that are mandatory already. The only thing I would say is, and Ross showed it earlier, is whilst we made great, huge leap forwards with MRSA bloodstream infections, we've not really done anything with MSSA. So overall, Staph aureus is still slowly increasing. So I still think we have work to do there. And then E. coli, just watch next year. E. coli is a big worry. We've seen a tripling of E. coli bacteremia probably over the last decade, especially in the community, especially of urinary sources. And I think that's one of the things we really have to focus on over the next couple of years. So this is just an example of some bits that we do here within Leeds. Tim, who was speaking earlier, this is part of his role. So actually looking at our C. diff cases and how we're doing against the objectives. So you can see some of the ones we've got some amber, we're a bit worried. And those we've got some green, we seem to be doing okay. And then there's something about collaborative action. So this is about working within your whole local health economy to look at sort of local outbreaks. And the reason is we know that patients come into hospital, they come in from this community. We know we have lots of people coming to visit our patients, often visitors, and again, they will often potentially bring infections in with them, and then we can potentially sort of spread them around. Again, normal sort of measures sort of in there, which is about sort of monitoring sort of outbreaks, and then really about joint working initiatives beyond those mandatory requirements. And I'll show you in a moment some of the things that we're trying to do in Leeds, looking at these. So within Leeds, we've had for a period of time, probably about 3 or so years, a control of infection. It's now being led very much by jointly twined public health and the council sort of leading in there. And you can see the membership that I've sort of listed sort of on there. So it has membership from all of the providers, including the independent sector. And if you think that the independent hospitals do 60% of their work is actually for the NHS. So it's really important that you get them involved with the work that you're doing. Council reps, public health, and then the quality managers or antimicrobial stewardship from the CCGs. We have 3 CCGs in Leeds, and we have one who represents all of them for doing this. We now have invited community pharmacy to join in because there's a big role about some of the vaccination role, and we've struggled to get sort of lay input. And in Leeds, we actually have a separate antimicrobial stewardship group. And so what I've put on here is I've literally just lifted from our last agenda to show some of the things we're looking at. So a bit about what's on the fingertips, and I'll show you something in a moment. We've set up an HI improvement group, and I'll talk about that in the next talk. Looking at local antimicrobial resistance patterns, sharing good practice we learn from, a bit about Zika virus coming up, We have a standard item on seasonal flu and pandemic, any outbreaks, and then any things we want to take to the Leeds Health Protection Board, so things we really want to sort of flag up, and then any national dates about, and we put on here the sustainability transformation plans, which will affect for the whole of West Yorkshire. Hands up if you've ever had a look at the Public Health England fingertips. Anybody? A few people? Hands up if you haven't. Hands up if you're so tired after eating you can't move your arms. Yeah, a few. At least you can laugh a little. So this is a fabulous resource, and this is what we want people to use. So this is what it's going to look at in the next week or so when it's updated. So it's focusing on 5 areas: antimicrobial resistance, antibiotic prescribing, healthcare-acquired infections, infection prevention control, antimicrobial stewardship. And you can see the titles on there with various drop-downs. So I've just clicked on the drop-downs for healthcare-acquired infections, and you can see it will pick up all the mandatory things, either at a hospital level or CCG, but it will pick up things like surgical site infections, the number of C. diff toxin tests we're doing. It allows you to compare various bits and pieces like that, blood cultures, and then some of the SSI work on there. And this is just a snapshot looking at hip prostheses for SSIs, which you'll probably hear about in a moment. And whilst these aren't comparable, it does give you a bit of an idea if you're thinking, actually, how do we compare with some of the other trusts that are out there? And it will give you indications on the number of infections there are and then the rate of infection sort of out there. And this is all about using data to try and drive action and further investigation. And you can see it will show you how, I don't know how well it comes out on here, but the purple blob is where you are. So I think this is Aintree because they happen to be the first in the alphabet. So they're slightly higher on C. diff reporting compared to the red line, which is the mean. And then it's got 25th to 75th percentile ranges in the dark grey. And then under the bottom bit, you can see the improvement of how it's doing against the England average. So it allows you to see how you compare to elsewhere. And then I've just pulled off E. coli bacteremia counts that exist on there. This is Liverpool, CCG, and you can see they're making fairly good progress. And I'm not sure what happened really moving at the end of the last financial year where they've seemed to started going back up again. So it actually makes you think, actually, what's sort of happening? Is there something in the community we need to focus on? Are we having problems in nursing homes, things like that? Then there's responsibility of hospital staff, and I'm not going to go over this, but this is that's already embedded into practice about learning and doing e-learning on an ongoing sort of basis and continual improvement. But the bit I did want to sort of flag up, which is useful on here, is, and you can't quite see what it is yet, and this fits into one of the sequins that are coming through this year, is actually flu vaccination rates. You can actually see how you're doing against sort of other organisations on there, and you can sort them on sort of values and everything else like that. And then I've picked, really cruelly, on the University of Hospital South Manchester on the right-hand side, you probably can't see it, who were doing fairly well in their vaccination rates, but last year something went wrong, and they went down to the sort of the national mean. So it allows you to look at your performance over a period of time, and that's why we've now got a very large sequin linked to getting all our staff vaccinated by the end of the calendar year. Planning, design and management of hospital facilities, you all know about this because it's already currently sort of embedded into practice on there. And it's just picking up from the Department of Health, health building notes are out there. And then the final element is, again, is the admission, discharge and transfer. So this is about having information about any infections and associated treatment shared as we sort of move on. I think for me, one of the big elements which we fail on is where we pick up infections after a patient has been discharged. So how often do we take 4 days to get a result from an MRSA screen and the patient's gone home 2 days earlier? Do we all actually follow them up by sending this out to the GP so they're aware of everything else sort of on there? I think that's one of the things we end up having to do. And so some of the indicators about picking up the percentage of admissions or transfers, colonisation info overall to see if we're improving. So that was really a very quick whiz through where we are with that. I would say go back and just see how your action plan's doing. This should feed into your trust quality account. So this is an annual statement that we have to give to our commissioners, just showing that we're continually improving.